This is a major side effect of our chemotherapy that I need to address, particularly in that there is both physical and an emotional impact of the side effect. It can be very stressful for both the patient and the family. Neutropenia officially means a decrease in neutrophils. It's kind of stated broadly as decreased white blood cells, and this is what really increases somebody's infection risk. It makes them prone to bacterial, viral, and fungal infections. Recovery time is in weeks, actually. Many infections, believe it or not, are actually caused by an overgrowth of the patient's body's normal flora. I know, right? So let's look at teaching our patients some really critical infection prevention measures, such as avoiding crowds, avoiding buffets, don't change litter boxes. Do report a temperature greater than 100 degrees, not 101, I said 100. Frequent hand washing. If you do touch a pet or animal, please make sure that they are cleaned and have good hygiene. Wash the axillary and perineal area once a day. We cannot allow them to defer personal hygiene. That is a big no. Even if they're tired, they need to do those two important places. Do know that we are not going to see purulent drainage on this patient. So if they have an infection, I would never, ever say, well, it's not like it has purulent drainage. No, they don't have white blood cells to make pus. So look at all of our other signs and symptoms and do know that pus will not be there, but an infection may. That feels weird, but that's how it goes. All right, so to do a total assessment for infection, please check their skin folds, their mucous membranes inside their mouth and the anus, their lung sounds to see if you hear crackles. Please check their venous access sites, such as their metaport. Double check the urinary system. Do they have burning upon urination or pain, Check their vital signs. Besides the temp, do I see tachycardia and tachypnea? Tell them to report a cough, a pimple, or any other kind of drainage. No sharing of equipment. Oftentimes we are going to establish a vital sign machine in a person's room, and that will be their vital sign machine for the duration of the hospital stay. Now, if there's not enough to go around, please make sure to clean it very well before bringing it in and on the way out. Okay, yes. Please make sure to report those temperatures greater than 100 and initiate the sepsis protocol if they do spike a temp. Well, what's the sepsis protocol? This means you're going to sample somebody's blood and do a blood culture. You're going to grab a urine and do a urine culture. If they have sputum, like the ability to spit something up, you're going to grab that and do a sputum culture. If they have a central line, culture that. If there's a wound, culture that too. Guess what? You're not done. You're going to do a chest x-ray to look for any kind of pneumonia, and you will likely start them on antibiotics. Phew! Anemia and thrombocytopenia is also a component to the full myelosuppression experience. If a person is anemic, physically we will notice that they are going to be fatigued, they're going to be dizzy, they're also going to complain of shortness of breath or hypoxia, and if we were to check their lab levels, we're going to see that their hemoglobin is actually less than 10. Now, what's the normal for men? Do you remember? The normal hemoglobin is 14 to 18, and the normal hemoglobin for females is 12 to 16. For our patients who have low platelets, their platelet level that gets lower than 50,000 is actually pretty dangerous. Do you remember the normal platelet levels? It's about 150,000 to 400,000. Now, if somebody's platelets drop even lower than that, such as lower than 20,000, then they are going to have spontaneous, uncontrolled bleeding anywhere. And we'll also notice that have these little dots on their skin called petechiae. This is a pretty dangerous situation. We are going to make sure to initiate bleeding precautions when their platelets are less than 50,000, and I talk a little bit more of what that includes on the next slide. But for now, if we would like to boost a person's blood cells, we can give them something called a biologic response modifier. What this is going to do is actually stimulate the red bone marrow to produce more of those cells. However, this does have a downside in that it can cause fluid shifts and fluid retention. This means our patient can go into shock. However, I personally have not had patient had a negative outcome from these medications. It's always important to be aware of that. So, what are some common signs and symptoms? It kind of feels like the flu, to be honest. Patients are going to complain of fever, chills, rigors, and other flu-like symptoms such as like muscle aches, and they're going to report bone pain. That is a pretty bad nuisance. They're probably going to be bedridden for a few days. Now, for somebody who has the rigors, which is like really intense chills, like you're going to go ahead and give them Demerol, also known as meperidine. The thing about this medication is it is a opioid. It does run the risk of causing seizures, so it's not something we just want to run to go give. But if somebody does have rigors that cannot be controlled by getting the fever down and getting a person comfortable again, we can give Demerol. It works pretty instantly, and it has all those lovely side effects of opioids, right? Such as hypotension and suppressing the respirations. I know, fun. Can't just give a med and everything be fine. It's always a downside. As promised, this is Randy. He is the keeper of all things bleeding precautions. When it comes to Randy, make sure our patients have electric razors, not razors with blades. No aspirins and no NSAIDs. I know, NSAIDs are included in this category. So no ibuprofen, no naproxen. If we do have to poke them with an IV or draw blood, use the smallest needle possible. And decrease the number of sticks, like cluster. How many, if you got to do labs, do them all at once. Protect from injury at like all costs. So if they have, like you need to move them up in bed, make sure to use a lift sheet rather than drag them up in bed so they don't get a skin shear and then bleed from that. Take a look for blood in the toilet, either from hematuria or melena. Look for epistaxis. How about gingival bleeding and spontaneous bruising, which that is actually going to occur, but any of these signs that you see down below, that should indicate to us our platelets are low, maybe below 20,000, dangerously low. And if they do get to that level, by all means, please request a transfusion if the doctor hasn't already ordered one. One of the most common and distressing side effects of chemotherapy is nausea vomiting. There's a couple different types. There is anticipatory nausea vomiting, acute, delayed, and breakthrough. One major thing to keep in mind is that we need to give the nausea vomiting medications as scheduled. So not just, hey, do you feel like you have nausea? Nope, it's going to be too late once they start throwing up. Just keep it coming around the clock. Not to mention that our older adults are going to dehydrate very quickly, and they're going to have electrolyte imbalances that are going to be hard to control. A group of medications that is going to be very useful in controlling nausea vomiting are called serotonin antagonist. A prototype drug is called ondansetron, also known as Zofran. These have shown to be very effective in assisting patients with maintaining their nausea, vomiting, and getting it under control, another thing we can use are steroids, such as dexamethasone. Guess what that's going to do to your sugar? Yay, if you're diabetic. And I believe, oh, one more thing about the anticipatory nausea, vomiting. I probably found this little fun fact, or fact just intriguing to me, that chemo patients, just the very thought, sight, and the sound of chemotherapy prep, even like a beeping, just them thinking about the next round of chemo can induce nausea, vomiting episodes. It's crazy. All right, next we're going to talk about is mucositis, also known as stomatitis if you have breakdown inside the mouth. Person needs to make sure to have excellent oral hygiene. This means they are going to be rinsing with saline and maybe even baking soda, maybe after meals and at bedtime. We need to make sure to clean their toothbrush in bleach weekly. Don't forget to rinse that bleach out. These sores are extremely painful and they do interfere heavily with eating and a quality of life. Patients can drop weight significantly if they have these. We need frequent assessment and oral hygiene, such as the saline rinse. Do make sure if they use floss to be very gentle with their teeth, and if they use mouthwash, it should not be alcohol-based. Okay, alopecia. If a person has hair loss, we need to encourage them, if they are wearing a helmet, headphones, glasses, or a wig, to inspect their scalp with a mirror. We don't need any skin irritation because the hair actually does provide some kind of protection for their skin. We also need to discuss avoiding scalp injuries, such as avoiding direct sunlight. Do try to put them in control of their appearance. Some patients want to shave their heads. Some want to leave what hair they have left as long as it can possibly be, even if it looks like the picture up above. Some want to always disguise it under a wig or a scarf, and some patients are the opposite, and they feel that bald is better, and they will not cover it because that is caving in. It really just depends, but whatever it is, please support the patient and do let them know that the American Cancer Society has a wig loan program. They also have makeup tips for like eyebrows and eyelashes, and tips on how to dress your head with a scarf. Do know that the hair loss is temporary and it will regrow in a different shade, texture, and thickness. Usually after 2 years or so, it will revert back to whatever the person's normal hair was. Cognitive changes. Oh, this is frustrating for me. I feel so bad for patients. But this is an unfortunate side effect where patients have the reduced ability to concentrate. They have difficulty learning. Oftentimes they cannot find the right word for something, and their memory is poorer than usual. Not poorer than usual, it is poorer. Unfortunately, nothing can be done to prevent these cognitive changes, and no one can say who's at more or less risk for it. Like, there's not a medication that puts you more at risk for it than another. The best thing we can do is listen and affirm with them that they are not alone. Refer them to the American Cancer Society for interventions for chemo brain. Those interventions basically include use of technology and other memory aids. Do know that recovery is likely. However, chemo brain, as we call it, can last for months to years after chemotherapy treatment. Last, we're going to discuss chemotherapy-induced peripheral neuropathy. This is where we're going to have a loss of motor or nerve function related to the exposure to the drugs, especially vincristine or Oncovin. Problems include loss of sensation in hands, feet, erectile dysfunction, severe constipation, orthostatic hypotension, and even taste discrimination. Please make sure that occupational therapy is on the team. The higher the dose of the medication, oftentimes, the greater the neuropathy. There is no cure for this, and it is likely permanent. Do teach a person injury prevention, laxative use, and there's one more thing I was going to add. Oh, taking medications for peripheral neuropathy, such as maybe Neurontin or gabapentin. There are several oncologic emergencies that we need to be cognizant of, that our patients are at risk for, and I need us to know not only what they look like, but how to treat them. The first one is sepsis, also known as septicemia. If we have a patient with septicemia, they're going to begin exhibiting slurred speech, achy muscles, oliguria, some dyspnea, feelings of like you're feeling so bad that you may die, and they're going to have cool, mottled skin. If you see this dangerous combination, they need to get immediately to an ER or to us in the hospital, and we're going to start aggressive antibiotics, and we're going to follow a sepsis protocol, which is where we're going to sample every bit of fluid that their body produces, and we're going to see what invading bacteria is overtaking their body. Do know that normal flora can actually be an organism too that becomes overwhelming for them. Now, if we are not able to reverse the septicemia that has begun in our patient, it may very well. When it comes to oncologic emergencies, nurses need to know what are the signs and symptoms, what are the signs and symptoms, and what is the treatment for the oncologic emergencies. The first one is sepsis, which is, as you can imagine, the result of having low white blood cells. Our immune function is impaired, and now we can have a deadly infection. Our patient is going to present with slurred speech, achy muscles, oliguria, dyspnea, feelings of impending doom, and they're going to have mottled skin that's probably going to be cool and discolored. So one of the things we're going to do when this patient comes in is initiate the sepsis protocol, which means pretty much take a sample and culture any orifice and any bodily fluid. So that involves chest x-ray, urine culture, central line culture, blood culture, sputum culture, if that's even there. Yeah. Okay, so you're going to do all the cultures and initiate IV antibiotics. Well, what about the next one? Disseminated intravascular coagulation, also known as DIC. Well, this unfortunately is a complication that may occur after the event of sepsis. So first sepsis and then DIC. DIC is when there is extensive clotting in small vessels. The patient will then have blood blocked in the small vessels, which go to small vessels into vital organs as well. Then all of our clotting factors are then going to get used up, and then the patient is going to now begin to bleed out. If this occurs, anticipate extreme pain in your patient, stroke signs or symptoms, tachycardia, dyspnea, as everything's infarcting really, decreased kidney function, which will then go into metabolic acidosis and eventually death. If this occurs, please make sure that the patient is in ICU. They are receiving IV antibiotics because oftentimes Sepsis is what initiates DIC. Place them on heparin drip so they don't use up all of their clotting factors by clotting. Do give them give them some platelets and fresh frozen plasma, which has all those little clotting factors. So what is the best management of DIC? The answer is very simple. Sepsis prevention. Please remember that. Sepsis prevention. And to recognize if somebody is developing DIC, we're going to do some lab work as well as looking at some of those signs and symptoms that I mentioned earlier. The labs include elevated D-dimer, prolonged PT or prothrombin time, low fibrinogen levels, and of course low platelets. Fun fact, D-dimer is a lab level that usually gets elevated anytime somebody has the clotting process happen inside their body. So you'll see it elevated in trauma victims, that seems normal, but you'll also notice it elevated in somebody who has a DVT or a PE. So if you ever wonder, why are we drawing a D-dimer? Well, they're checking out and seeing if somebody has clotting going on inside. All right, now SIADH, that stands for Syndrome of Inappropriate Antidiuretic Hormone. Our signs and symptoms of mild SIADH include a drop in sodium, followed by weakness, muscle cramps, and fatigue. If we don't intervene in our patient, then they're going to develop late signs and symptoms of SIADH. And that looks like an even lower sodium level. And now we're going to have weight gain, personality changes, confusion, and extreme muscle weakness. They will be bedbound here and very confused. If we are not able to reverse the SIADH syndrome that's going on, then we're going to have even lower sodium levels and we're going to develop seizures, possibly coma, and death. Some of the nursing interventions include restricting water for this person. We're going to let them eat as much salt as they could possibly handle. Right? We got to get their sodium levels back up. And drug therapy. That actually includes giving declomycin. Now this actually, interestingly, is an antibiotic. However, this antibiotic has the lovely side effect of reversing and preventing the antidiuretic hormone from being produced. So if we can reduce that, we are going to then get our body back into the normal hemostasis. Please do observe your patient for signs and symptoms of fluid overload. And know that syndrome of inappropriate antidiuretic hormone is often the result of a tumor secreting excessive ADH. So we're going to block the production by giving the declomycin, and then we're going to try to kill the tumor. How does that happen? We're going to probably give immediate radiation therapy and chemotherapy to that patient. There's a few cancers such as prostate cancer, lung, breast, colon cancer that likes to metastasize to the spine. We call that spinal mets or spinal metastasis. And if this is the case, a tumor is going to actually invade the spinal column and cause vertebral collapse. And that is not good, because if we have impingement on the nerves, then we can actually, if not relieved promptly, we're going to have permanent damage. So surgery for the tumor removal or stabilization is required in this case. Well, how are we going to know if this is happening? Well, a person is going to start having back pain, and then their deficits are going to follow. And the deficits are going to be very specific to the level of compression. If it's a little bit higher, such as in their thoracic area, then we're going to have problems from that level on down. Versus if it's in a lower spine, like the lumbar or the sacral spine. So deficits are going to actually vary, but do assess your patient for back pain, leg numbness or weakness, the sensation of heaviness in their limbs, maybe unsteady gait, constipation, or incontinence actually of bowel and bladder. If they have a new onset of bowel and bladder incontinence, do know that that is a major indicator of a problem in the spinal column. What are our nursing interventions? This is going to include palliative surgery. Usually we're going to give our person high-dose steroids, high-dose corticosteroids. We're going to use high-dose radiation and probably place our patient in an external neck brace or back brace if surgery is not an option. The next oncologic emergency is hypercalcemia. This may develop slowly or quickly, and symptoms depend on how quickly and how high the calcium rises. Some of the guilty cancers that do this are breast cancer, lung, leukemia, lymphoma, just kind of about all of them actually. These cancers tend to secrete hormones. The one hormone that I'm thinking of is parathyroid hormone. And this is going to cause the bone to release calcium. And unfortunately, if we have patients with decreased mobility and if they are dehydrated, they're actually going to lose a whole lot more calcium a whole lot quicker. So what are the common signs and symptoms of hypercalcemia? It's going to be skeletal pain, abdominal discomfort, altered cognition, and fatigue. If we move to failing to intervene, we're going to look at some serious signs and symptoms of hypercalcemia. That includes extreme muscle weakness, loss of deep tendon reflexes, an paralytic ileus, and EKG changes. Some nursing interventions include oral hydration. Drink, 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 drink. Or if they can't drink, give them IV saline. We're also going to give them loop diuretics. I know, how does that work? You're hydrating somebody and you're giving them diuretics? Yes, I am. I am trying to get their kidneys to let all that lovely calcium out. The water will come too, but I need the calcium to get out. You're going to give them biphosphonates, just like we're given to our patient who has estrogen therapy. You're going to give them calcitonin. That's going to reverse the release of parathyroid hormone, kind of antagonize it, I should say. And our person may even need dialysis for their hypercalcemia. Last but not least is superior vena cava syndrome. This to me is a very fascinating syndrome, as we can actually see in our two pictures here of some situations of SVC syndrome. It can occur either quickly or over a period of time. This does cause significant pain, and we consider this life-threatening. Some cancers that this will occur in are lymphoma, lung cancer, and breast cancer. Some early signs include swelling in the upper extremities after sleep, meaning from their armpits up, they are going to have facial edema, arm edema. It's usually bilateral, and it gets really bad when they lay flat. In fact, a patient oftentimes, if you ask them, they will tell you, yeah, I don't lay flat anymore. I sleep in the chair because my face tends to swell up. That's an indicator that their blood flow, particularly at the area where the superior vena cava pours into the right atrium, it's blocked by a tumor. Now, some late signs of SVC syndrome include engorged upper body blood vessels. You can't really see it very well on the baby. However, it's kind of clear enough, I guess maybe you can pick up on it. The baby has these very large superficial vessels, and that is because of the blocked SVC syndrome. They're going to have extreme edema in the face. Their eyes may even swell shut. They're going to have no wrinkles anywhere in their face. And then if you check their hands, they're going to complain that they can't wear their rings anymore, their bracelets, they can't button their shirt collar. Some deadly signs are if they have hemorrhage, cyanosis, and hypotension, if they're hemorrhaging. Ugh. All right, so what do you know? It is life-threatening. Keep that in your mind. After you see these, make sure your person gets a CT scan or an X-ray stat. And the nursing interventions include, obviously, recognition, but we're going to do high-dose radiation, like that day. We're going to do chemotherapy. This is usually for long-term control. And an angioplasty. This is where we're going to stick in their superior vena cava a little catheter, and then we're going to inflate a balloon, and it's going to widen the vessel some. Make sure to sit your patient upright or elevate the head of the bed. Give them oxygen, PRN. Steroids, please, such as dexamethasone. We can also do Lasix or furosemide to reduce the intravascular volume. And if they have dyspnea, you can give them opioids for the air hunger. The last oncologic emergency is called Tumorlysis Syndrome. Tumorlysis Syndrome. As I mentioned at one point, patients who have bulky lymphoma are possibly going to get Velcade. This is this medication that oftentimes will destroy a lot of these tumor cells, and if they have a high tumor burden, it will destroy a lot of them at the same time. And this is likely to occur after the first treatment of tumor. So if it occurs, you're going to notice that your person has lethargy, some nausea, vomiting. They're going to have very cloudy urine, flank pain actually, and muscle weakness. One of the main things we want to do is hydrate, hydrate, hydrate. In fact, in doing so, we're going to dilute all of the potassium that just got released out of the cells, and we're going to decrease the chance that our person is going to develop a kidney stone because of the lovely uric acid that is prone to develop kidney stones. So when I say hydrate, 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 we're going to make sure it's about 3,000 milliliters per day. That could be IV or it could be PO. We're going to make sure their IV fluids have sodium bicarbonate added, because this person is going to have a nice case of metabolic acidosis. Make sure to get them on an antiemetic regimen because they are going to be having lots of nausea, lots of vomiting. We're going to put them on a medication called allopurinol or Xyloprim. This is to help release the uric acid from their bloodstream. They're going to void it out. Because the potassium is so high oftentimes, to get it to go lower, we're going to possibly put our person in ICU on an insulin drip with concurrent IV running of dextrose. This is what we do in extreme cases of hyperkalemia, and what we are accomplishing by doing that is when we administer insulin and sugar goes into the cells, insulin also unlocks the cells for potassium to go back in. So that is what we're going to do to monitor their hyperkalemia. If we cannot get it down soon enough and we're having some cardiac complications, we're possibly going to do dialysis for a patient. This picture here is a patient who had bulky lymphoma, and she, as you can imagine, has a high tumor burden and experienced Tumorlysis Syndrome after the first cycle of chemotherapy. Okay, we're good. So when it comes to your cancer patient, do know that they often report feeling isolated and feeling lonely. A lot of the roles and responsibilities that they have had to be changed. And fatigue is like the longest lasting symptom, so please make sure that they get enough rest and participate in low impact exercises. Do know that part of discharging them, we have to make sure that they are going to a clean home near a local hospital that has telephone access and that they themselves are emotionally stable, or maybe their caregiver is emotionally stable. If this isn't the case, oftentimes patients will go to a skilled nursing facility, or a case manager can research and help apply for the patient to have funds to stay in like a clean home. All right, so what is remission? I should probably make sure students, after this whole long lecture, understand that remission is somebody who has been cancer-free for 5 years. And 5 years is extremely special because that means if you have passed the 5-year mark, there is a really high probability that you are cured and that you are going to keep on living for a very long time. So survival rates after 5 years are significant. So everybody is excited about the 5-year number. All right. I think we're good here. In closing today's lesson, I show you a picture of a little girl with cancer who had a grim diagnosis. You know, after losing her hair, all she wanted to be was Rapunzel for Halloween, and she actually went back to the nursing unit to show off her new do. So as nurses, we can't promise to give a patient this long, happy, pain-free life. We can't do that. But we can give them just a hand, a smile, our tears, and evidence-based nursing care. And that's what they ask, and that's what I feel like we owe them. So let's go back to our objectives and see what we can continue to focus on as we tackle this really large chapter. Be sure to remember the cancer terms and make sure you can define them. How about the interventions, such as surgical interventions, radiation interventions, chemotherapy interventions, as well as hormone? Do remember your health provider safety, whether it's chemo or radiation. Protect yourself. Management of all of those side effects. Oncologic emergencies, recognizing and treating. And last but not least, psychosocial care. If you can nail down those topics, you are going to do just well on this exam. Thank you so much.